Assalamu alaikum everyone. Thank you very much for joining today. We're very fortunate to have Dr. UMAR EBRAHIMSA who will be speaking to us about COVID-19 and the vaccine. But before we start the main program, we're going to have a recitation of the Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إذا جاءك المنافقون قالوا نشهد إنك لرسول الله والله يعلم إنك لرسوله والله يشهد إن المنافقين لكاذبون اتخذوا أيمانهم جنة فصدوا عن سبيل الله إنهم ساء ما كانوا يعملون ذلك بأنهم آمنوا ثم كفروا فطبع على قلوبهم فهم لا يفقهون وإذا رأيتهم تعجبك أجسامهم وإن يقولوا تسمع لقولهم كأنهم خشب مسندة يحسبون كل صيحة عليهم هم العدو فاحذرهم قاتلهم الله أنى يؤفكون وإذا قيل لهم تعالوا يستغفر لكم رسول الله لووا رؤوسهم ورأيتهم يصدون وهم مستكبرون سواء عليهم أستغفرت لهم أم لم تستغفر لهم لن يغفر الله لهم إن الله لا يهدي القوم الفاسقين هم الذين يقولون لا تنفقوا على من عند رسول الله حتى ينفضوا ولله خزائن السماوات والأرض ولكن المنافقين لا يفقهون يقولون لئن رجعنا إلى المدينة ليخرجن الأعز منها الأذل ولله العزة ولرسوله وللمؤمنين ولكن المنافقين لا يعلمون يا أيها الذين آمنوا لا تلهكم أموالكم ولا أولادكم عن ذكر الله ومن يفعل ذلك فأولئك هم الخاسرون وأنفقوا مما رزقناكم من قبل أن يأتي أحدكم الموت فيقول رب لولا أخرتني إلى أجل قريب فأصدق وأكن من الصالحين ولن يؤخر الله نفسا إذا جاء أجلها والله خبير بما تعملون صدق الله العلي العظيم.
Thank you very much for that beautiful recitation. We're now very fortunate to have Dr. UMAR Dr. Ibrahimsa is an infectious disease specialist and a member of our community here, and we're very fortunate to have him speak. He has previously spoken extensively on the topic of COVID-19 and is a very popular guest with our audience, with many people coming, listening in from all around the world. With thousands of people having listened to him last time, we'll see what happens this time if they want to come back. So without further ado, I'd like to have Dr. Ibrahimsa speak, or Omar speak for quite a short period of time, maybe 15-20 minutes or something. And if there are any questions, we'll keep them on. And if you do have any questions and you're on YouTube, please feel free to put them on the YouTube chat, and we'll try and ask them. But we're going to try and keep things a bit shorter today than in the previous session with him. The goal being to really have a social discussion afterwards, which won't be streamed. So we'll have 15-20 minutes of actual lecture or talk or presentation, and then about 10-15 minutes of Q&A, which will be streamed, after which we'll switch off the stream, and it'll only be those who are here on Zoom. If you are on Zoom, please do put him on Spotlight, or put him or pin him so you can see him directly if that's what you'd like. Or on YouTube, we look forward to listening in. Thank you very much. And Omar, without further ado, please unmute yourself.
Assalamu alaikum. Am I, is it clear, Mr.?
It's perfect. Thank you so much, Omar.
This is, as Migdad mentions, a pleasure and an honor, and the attendance that he hints at previous events is probably a marker of just how significant this pandemic has been for us, rather than anything to do with my expertise in it. For my day job, I work as a infectious diseases specialist and general medicine registrar in East London, but I'm attending here in my own capacity. And what I wanted to do was just to very briefly recap what we had discussed previously. And in my previous presentation, I'd gone over the process of vaccination, the different mechanisms of vaccination that we have, and the types of vaccine that are available for the management of COVID-19. So where do we stand today? We are in the midst, hopefully at the tail end, of a second wave of infections that have swept across the United Kingdom, across Europe and North America. And where the first wave in spring, where we were entirely, if you like, where we were entire novices and had not had any opportunity to prepare as we would have wanted to prepare for this. We have then had about 6 to 9 months to anticipate the second wave. In the first wave, 60,000 people died. And the government's own calculation and anticipated mortality from the second wave suggest anywhere between 100 and 120,000 people dying now. These are based on estimates released in the summer. So as you can see, in terms of mortality alone, this is a more significant situation. And at this point in time, key to driving that mortality is actually the overall number of people who have suffered from coronavirus. So as we discussed previously, coronavirus is a virus that affects the upper and lower respiratory tract. It affects your nose and it affects your chest. And it's spread by the production of droplets by the person who is unwell, and they're breathing in, or they're being breathed in by others in their near vicinity. Generally, this is the main mode of spread. And what we've seen occurring in the UK, and what was identified at the beginning of December, was a new variant of coronavirus, which seems to be almost 50 to 70% more infectious. But despite this, it does not seem to cause as much severe illness. However, due to the sheer number of cases that have, or number of people who have been infected, the total number of individuals with severe illness, and as a result, then the total number of those dying, has been much higher than with the previous types of coronavirus that we faced in spring of 2020. So in the interim, our hospital capacity has increased marginally, and our understanding of the disease has certainly improved. And in this sense, the United Kingdom, the NHS in particular, has led the field in generating the evidence, the basis for treating individuals with coronavirus. So we know that anyone who has an oxygen requirement would benefit from the use of dexamethasone, and more recently, an immunomodulatory drug called tocilizumab, which is sometimes used by rheumatologists, has been shown to be of use, again, in patients with severe COVID-19. What we lack are effective treatments of patients with COVID-19 in the early stages, i.e. those in the community. There are no antibiotics which are effective against COVID-19. This is a viral illness. And the knee-jerk response in the early stages of needing to do something and prescribing people antibiotics which are potentially quite destructive to them in the long term has thankfully diminished, and there's more appropriate prescription that's occurring. So we have a better understanding of the disease. However, the most significant change between the spring and now is the presence or the availability of vaccine. Within a year of the virus being identified, and within a few months of its genome being sequenced, there has been a tremendous scientific effort that's produced a vaccine that can be used and is remarkably effective. And it is the reason for this occurring within such a short time. If you think back, the mumps vaccine in the 1960s, 70s took 4 years to produce. This has been produced within a year. The main reason for this is that a phenomenal amount of resource has been devoted to it. And we have been able to carry out studies at speed, where normally you would carry out a study, wait a while, carry out the next study. So your phase 1 study, then your phase 2 study, then your phase 3 study. In the current environment, studies have been going on simultaneously or with very short time gaps between them, and all pre-funded. And the management of the coronavirus crisis in countries such as the UK, the US, and Brazil has ensured that there are a huge number of cases that have occurred, that the disease has spread through the population and affected large numbers of individuals, partly because of the mismanagement of the situation by governments. But this has then meant that trials that have been carried out have been completed far earlier, because we are detecting many more cases than we had anticipated originally. So that shortens the amount of time required to do a trial to assess how effective a vaccine is. And the vaccines that have come to market have been of two main forms, at least the ones that are in the UK. One, an mRNA vaccine, which is delivered through a lipid, if you like, in a lipid vehicle. And this is what Moderna and Pfizer have produced. And the other, a viral vectored vaccine produced by AstraZeneca and Oxford. The mRNA vaccines have between them shown vaccine efficacy in the range of 90 to 92%. So very, very effective when one compares with, say, the annual flu vaccination between 30 and 60%. So what does that mean? That means that out of 100 people receiving the vaccine, 90 to 92 individuals in that group will not develop the illness, will not contract COVID-19. But the flip side to that is that between 8 and 10 people will. And these are vaccine efficacy calculated within trial conditions and with close monitoring of participants. We anticipate that there will be a reduced efficacy within the mass rollout that we're seeing. And this, however, would not prevent me from recommending vaccination. And I think the main challenge that any community today faces is then getting hold of this vaccine. We are going to be affected by a prolonged process of vaccine scarcity. The AstraZeneca vaccine that's available in the UK will be produced at 2 different sites here. The Pfizer vaccine is being produced in Belgium, and already Pfizer has suggested that it will delay the release of doses to Western Europe during the first quarter of this year. As a result, in this process or context of vaccine scarcity, it becomes important that we have a means of administering this vaccine appropriately. The question becomes one of what is appropriate. And the UK has decided upon focusing upon preventing severe illness and reducing mortality. So focusing upon groups who are likely to develop severe illness or individuals who are likely to die if they develop the illness as well. And this is tightly associated with age. So the older you are, particularly above the age of 70, the higher the rates of death that we find in these age groups. Having said that, even in these age groups, even in the 80 plus age group, the majority of people who contract the illness will still have a mild illness. It is just that those who have severe illness and those who are at risk of death are 20 times more so, or 20 times more at risk of death than those below the age of 50. As a result, we have the 4 main tiers that who are being vaccinated. So care home residents, those above the age of 80, and frontline health and social care workers, then individuals between the age of 75 and 79, and subsequently individuals above the age of 70, and those who have been recommended to shield because of underlying medical conditions. And the aim is to vaccinate approximately 15 million people amongst this group by the middle of February. And that would represent about 99%, between 90 and 99% of the anticipated mortality from coronavirus. So I think the significance here is that I anticipate the problems that we will face being those of inequality of access and variability in rates of vaccination across the country. And if you look just at the over 80s in England, you live somewhere like Northumbria, up by the Scottish border, 70% of individuals over the age of 80, so this is tier 2 and above, would have been vaccinated. Whereas if you look at London, less than 50% have been vaccinated. As a result, if we are to do something about this, it is in making the vaccine more easily available to communities. And how do we do that? Perhaps following the model that Birmingham has pioneered in enabling vaccines to be located within the community, within masajid, with appropriate support, and allowing masajid to become open centers within the broader community. Because ultimately, we're going to have to do this if we are to meet a target of vaccinating 2 million people on a weekly basis. So far, at best, we vaccinate about 300,000 people a day. And this is through a network of 1,000 GP-led sites and some 200 pharmacies in the main, 200 hospitals also involved. In addition to the 17 mass vaccination centers, which are due to come on stream. So they haven't yet been, they're not yet operating at speed. And that, to my mind, is the far more significant matter than the concerns that I had early on about vaccine hesitancy. Primarily because this vaccine is safe. More than 3 million people, in fact, more than 5 million people in the UK have been vaccinated with very, very few side effects. The side effects tend to last about 48 hours and resolve. And the early cases we've seen of anaphylaxis, severe allergic reactions, tended to occur in individuals who already had severe allergic reactions. And in the UK, unlike in Norway, we have not seen an unexpected number of deaths in the over 80s. So the recent concern about 23 deaths in Norway led to the Norwegian government encouraging doctors there to consider whether those who are multiply comorbid, have multiple underlying medical conditions, and are frail and are potentially close to the end of life, whether they need the vaccine. Given the fact that the vaccine side effects of fever, gastrointestinal upset, systemic or flu-like symptoms may harm them more than the likelihood of getting the virus if they are shielded. So even in that context, the advice for vaccination hasn't changed. And we're not seeing this played out in other Western European states, right? So the bottom line is that the vaccine remains safe. The concerns about vaccine efficacy in Western Europe do not seem to have been great. There is some concern that was voiced in Israel following their vaccination of about 2 million individuals. But again, they have vaccinated fewer people than the UK. And there, it is unclear what they were referring to, whether it is infections prior to vaccination, then manifesting following vaccination, or whether these are true infections following vaccination at a point in time when vaccination should be effective. So as far as we can see, the efficacy remains as expected. So in that context, the main challenge then is delivery and access. And on that note, I'll conclude and enable people to then ask questions and we can discuss further.
Thank you very much, Omar. We have obviously time for questions. So if there are people who have any questions, please raise your hands on the chat, or alternatively send a message, a WhatsApp message, or send a note on YouTube. So the first question that's come through is related to what happens in the long term. Do we know whether this vaccine actually is likely to last 3 months, 6 months, 9 months, or 12 months? And if it's only going to last 3 months, what's the point?
So the follow-up studies prior to licensing all followed up individuals participating in the trials for a period of at least 2 months. And the majority were followed up for at least 3 months prior to publication, and they will continue to be followed up for 2 years. And at the 3-month stage, there doesn't appear to be a decline in efficacy. So it's unlikely that it will cease being effective after 3 months. More significant is perhaps how long it will last given the annual cycles of respiratory viral infections. So we tend to get respiratory viral infections in the autumn and through to the spring. And we're going through our first phase in the context of the vaccine now. We can only really assess whether there is enduring immunity after the next respiratory viral season, which will be next year. or which will be later this year, sorry, in November, December of this year. How else can we look at this? Well, if you look at immunity to SARS-CoV-2 infection, and there's some nice studies done again here in Oxford and by Public Health England, looking at individuals who've contracted the infection and who have produced antibodies. Now, although the antibodies may not be the main route through which you protect yourself, they might serve as a good marker of an effective immune response. So individuals producing antibodies who have had the infection seem to be well protected for at least 8 months. And there's no reason to think the vaccine will be any less effective at this point. So my rather long-winded answer to that is that it's likely to be effective for at least 6 months to a year from what we're seeing, and if not longer. But we have to wait and see.
Perfect. Zaid has a question. Please, can you unmute yourself and ask? Yeah. And ideally show your picture.
Thank you so much, Baghdad. I can show my picture, but I'm outside. Thank you so much, Baghdad, and thank you so much, Omar, for informative talk. This is a very selfish question. The fact that a lot of us only have had one dose. You talk about the vaccine as being vaccinated. So would you consider me as having had one dose as being vaccinated? How safe am I? When can you say I'm safe?
Do you mean when do you start to be protected by the vaccine, or when do you reach your optimal vaccine efficacy?
Yeah, I guess both. When can I feel confident about, just living life? I know there's no such thing as normal at the moment, but when can I relax about getting the virus and potentially ending up in hospital from the virus?
So I think that's a very good point, because it comes back to the whole question around what's the point of vaccination? Is it for the individual, or is it for the community as a whole? And what we are aiming to do in the first stage of vaccination is to protect individuals who are likely to suffer significant illness, and through that to protect use of the healthcare system, to prevent them being overwhelmed. And then subsequently, so below tier 4, when we start vaccinating individuals below the age of 70, and those who have no underlying conditions, we're then aiming to reduce transmission of the virus within the community. And the ultimate aim is to establish a level of immunity within the population, and we're looking at least 70 to 80% of the population being vaccinated, where transmission of the virus will decline, will reach the herd immunity threshold. And for the individual, what studies suggest at this point are that vaccine efficacy, if you look at the Pfizer and the Moderna, Pfizer, I think from about day 10, Moderna, again, from about day 10, day 11 onwards, there's a clear divergence in the development of symptomatic COVID amongst those who were vaccinated against those who were not. So from at least 10 days post initial vaccination, there is some protection. And if you look at the Pfizer cohort and you take out individuals who have had who develop infection within the first 2 weeks of vaccination, or let's say first 10 days of vaccination, that's individuals who are likely to have been infected prior to vaccination, then what you find is an efficacy of about 90%. So from day 10, post-initial vaccination, in this case with the Pfizer vaccine, and if you were to look at the AstraZeneca vaccine, we're seeing efficacies of about 70% and above at for the AstraZeneca vaccine as a whole. From that point, I think you can consider yourself initially protected. Then the question becomes one of why do you need a booster dose? The idea behind the booster dose is to enable a more mature, appropriate, potent immune response to develop. And for the AstraZeneca vaccine, the one from Oxford, there's good evidence that this can be delayed for up to 12 weeks. That's there within the trials. There's some controversy at present over the government's delaying the booster dose for the Pfizer vaccine for up to 12 weeks as well. Now, the Pfizer vaccine was delivered 21 days after the booster was delivered 21 days after the priming dose. So the second dose was delivered 21 days after the first dose. And this is more, I think, decided upon for convenience of running a vaccine program rather than necessarily having an immunological basis to it. So is there any evidence to suggest that immunity would decline, diminish, and disappear beyond 3 weeks? Not currently. And I guess in a situation where we have limited access to the vaccine, the question becomes one of what do we prioritize? Do we want at least everyone to have some level of, or as many people as possible, to have some level of immunity? Or do we want ideal levels of immunity achieved within a smaller cohort? And the modeling so far, this comes back very much a modeling question. The modeling suggests that we should probably continue and vaccinate as many people as possible with the initial dose of vaccine, and then extend out the time period for the second dose to 12 weeks. I hope that answers some of the questions, some of your points, Zaid.
Thanks so much, Omar. That's very helpful.
Omar, I'm going to, we've just had a flood of questions now. Can I ask you to, if possible, keep answers as short as you can, recognizing obviously you want to cover other points fully, but I'm going to ask 3 in a row, and then some of these are yes, no, very quick ones, so hopefully they can be answered. So firstly, from WhatsApp, since a lot of young people are dying at a higher rate, doesn't it make sense to start vaccinating over 50s hand in hand, especially when more vaccine supply comes on? That's the first question. The second one, is the new variant from South Africa or Brazil susceptible to the current vaccine? And the third one is, if you're clinically vulnerable and you get the vaccine, will it help your immune system? I'm sorry, they're not very related, but there's so many of them. Yeah.
So the data so far still suggests an overwhelming preponderance of death amongst those above the age of 70. There is a lot of media attention and a lot of focus, understandable focus, upon individuals below the age of 60 or individuals around the age of 50 who are suffering from this illness, but they are a tiny minority in comparison to the total numbers that we're dealing with. So I think that the current strategy is reasonable. And I think the point about mutations is a very reasonable point. So what do we see? Coronavirus, unlike flu, mutates very slowly, very, very slowly. But the effect of any mutation is dependent upon where the mutation occurs and what changes. And the mutations that we're seeing in Kent, so the Kent mutation and the South African mutation, and what I'm not so sure about Brazil, but at least in these two, it's the spike protein which has been altered, and it's the spike protein which we're using as the focus, the target for the immune system in the vaccines that have been produced. So the Kent variant seems to be covered by the vaccines that we've currently deployed, as does the South African variant. But it's a fair point, and this adds to Zaid's previous question, or the previous question with regards to how frequently we may need to vaccinate. And that may depend, again, on what kind of mutations are in circulation. However, the vaccines are designed in such a way that they are vehicles that deliver a vaccine. So altering that vaccine and bringing it out to the public could occur far more quickly once a significant mutation is identified. What were the other ones?
Okay. let me just ask a couple of other ones. Does exposure to traveling put vaccinated people to more or less immunity, from Mufti Barakatullah? And then separate to that is there any point in getting any other vaccine other than the Pfizer one, given the effectiveness numbers? And thirdly, do you think it has any impact if you have a vaccine, if the mother is if you're a mother who's breastfeeding?
So I think there was, from the last batch, I'd forgotten to answer one on immune compromised, immune suppressed individuals. So the challenge with vaccination amongst those who are immunocompromised, immunosuppressed, the very elderly, and the very young, is that they may not produce an adequate response to vaccine. So the issue is not that the vaccine is dangerous to them, but that they may not produce sufficient, there may not be a sufficiently pronounced immune response compared to those with who are immunocompetent. So I would recommend the individual speaks to their GP, but the current guidance is that all individuals with a history of immunocompromise or immunosuppression should be vaccinated, because these are not live vaccines, the three that we have or the three that we've discussed here. In terms of travel and immunity, given that the UK has been pushed out into the Atlantic Ocean by most of its European partners and the rest of the world, following the identification of the Kent variant, I think the issue here is I would recommend individuals who are thinking of traveling to think about whether they actually need to travel, particularly to consider what their underlying comorbidities are, whether they have heart disease, lung disease, diabetes, or have had cancer treatment recently, or renal failure, and to consider whether they would be willing to become unwell elsewhere without having been vaccinated in the UK. So I would recommend that they are vaccinated first before traveling, which may mean delaying their travel until that's possible. And immunity here is derived from either vaccination or infection. So travel alone will not induce immunity. Which were the other questions?
So the next question was about the efficacy of Pfizer versus others. Is it just worth taking Pfizer? And the second, the other one's breastfeeding.
So with breastfeeding, I'll come to that first, and the efficacy secondly. With breastfeeding, the advice has now changed, and I think it's quite sensible that we're now vaccinating breastfeeding mothers. There is no reasonable explanation for preventing a breastfeeding mother from having the vaccine. The vaccine, once injected, causes your body to produce the spike protein. The virus is not produced. Spike protein is produced. You then have an immune response against this, and you produce antibodies. Even if the spike protein is secreted with the breast milk and ends up in the infant's gut, it will be broken down within the gut as with any other protein. So the risk to the infant is infinitesimally small in this case, and the benefits are significant.
On that, someone else has asked a related question. Is it true one of the ingredients of the vaccine contains a chemical related to fertility, hence some young women are reluctant to take it?
There isn't in either the Pfizer or the AstraZeneca vaccine any chemical that is known to have any effect on fertility. On the other hand, having COVID-19 and lungs that don't function for a prolonged period of time might well affect fertility. And with regards to vaccine efficacy, I'd suggest that even with an efficacy of 70%, I would be happy to have the AstraZeneca vaccine, on the basis that actually with the 12-week delay, the group that underwent a 12-week delay in the UK cohort had a vaccine efficacy of about 90% in the trials of the AstraZeneca vaccine. Now, in the current context, 70 versus 90% in trial conditions versus the likelihood of developing COVID-19 from an infection within the community, I'd still plump for having the AstraZeneca vaccine.
Thank you. Just before I come to two people who want to ask in person, Ahmed and Khalil, just a couple of other questions that have come through. Firstly, Salam, nice to see you. Thanks for organizing Team Mahfil. The break in the interdose protocol sets an awful precedent. Do you know of cases when this has happened at such scale before? The second question is, whilst you've got no short-term effects of side effects because you've seen that, do you think there might be long-term effects that we may not be aware of? Or is it the case that because we have a vaccine which is of a similar type to others, we know what long-term effects are likely? And finally, even if you don't become even if you are vaccinated, but you get COVID again, are you likely to have less chance of being in hospital?
Can you repeat?
I think so. I think that that final question was mainly saying, when we talk about the efficacy of these, if we look at the efficacy of some of these, and you say it's 90%, for example, if you're in the 10%, are you just completely not protected, or is it the case that that cohort's been looked at and actually you're less likely to die or less likely to get severe illnesses, and therefore it still gets some value?
So you are likely to get some value. We know from the Oxford AstraZeneca study that individuals who are vaccinated, no one develops severe illness. Likewise, from the Moderna study, no one develops severe illness. And the incidence of severe illness amongst the Pfizer cohort is diminished. So one of the key markers, one of the key outcomes of this is that people don't develop severe illness on the whole with the vaccine, even if you subsequently contract the infection. And I think that stands in support of the vaccine itself. With regards to the break-in protocol, we live in unprecedented times. There has been no previous vaccine rollout that has vaccinated 5 million people within a matter of 5 weeks. So there would never have been this kind of break-in protocol before. I think this is a reasonable break-in protocol. There isn't where there is a risk that is taken, and the risk is this: that we don't have the we're delaying the dosage despite the shorter time period between the first and second dose in the Pfizer studies, and we don't know exactly what the on the basis of the trial data, we don't have evidence rather of what the efficacy would be if we were not to give the second dose within 3 weeks. However, there is no evidence of a rapid decline in immunity. There's no suggestion that there would be a rapid decline in immunity with that delay. So the issue of the break-in protocol, I think, is more one to challenge government about the ethics of this, rather than necessarily the risk of increased infection.
Otherwise, long-term effects, yeah.
As to side effects, so there's a reason here why follow-up has been focused on at least 2 months following completion of vaccination. And that is, when you review previous vaccines, you find that any of the long-term side effects that were noted tend to occur within 6 weeks of vaccination. So given the absence of any signal within 8 weeks, I think it's reasonable to assume that there will not be significant long-term side effects. The counter-argument to that is that these are all novel vaccines. This is completely new and untested and uncertain. So with the AstraZeneca vaccine, the platform has been around for at least a decade. There's a licensed vaccination against Ebola using this, and the trial data from that and the follow-up of individuals on the trial don't suggest long-term side effects, number one. With regards to the Pfizer and Moderna vaccines, the thing to bear in mind is that what those vaccines do is introduce a key bit of a key indicator into your cell that promotes protein production. That indicator is degraded, it disappears. In fact, the main challenge behind these vaccines is that that indicator disappears so quickly that getting it into the cell is a challenge. And once in the cell, it certainly disappears within 48 hours. So all components of the vaccine have been degraded by the body within 48 hours, and all that's left is the spike protein being produced by the body. And that's similar to exposing the body to spike protein itself, which a lot of traditional vaccines do. They expose the body to a particular protein. And none of those have shown signals for long-term side effects beyond occurring for the first time beyond 6 weeks. So I think it's reasonable to think that there won't be significant long-term side effects with this. But we have to wait and see.
Thank you very much. Should we go to Khalil? Would you like to ask in person, please? Please go off Zoom. Oh, please go. Yeah, there we go.
Umar, thank you for your talk. I just wanted to ask regarding the reinfection rates and whether there's been anything in the literature just regarding what sort of levels of reinfection we're finding and whether these are happening in any particular demographic. Certainly anecdotally, we're still sort of starting to hear a lot of stuff about reinfection.
Did you mean reinfection in individuals who've already been vaccinated? Or
No, this is not vaccinated individuals per se, but also, you know, if there is data about vaccinated individuals, I'd be surprised. But if there is, then I'd be interested to hear it.
I mean, it's still very early, as you mentioned. It's still very early to be able to collect data on individuals who've been vaccinated. That would be something that's underway, and the earliest we would be able to see what happens in that case would probably be after the spring. In terms of following individuals who have confirmed COVID and have been seropositive and looking at reinfection, there's the health worker study that was published in the New England Journal recently following a cohort of about 1,100 individuals from Oxford. So given who are seropositive versus 11,000 who are seronegative, but given that cohort, that's predominantly white middle class with a preponderance of women involved as well. But given those limitations, no one developed severe disease. In fact, no one developed symptomatic disease as they were followed up fortnightly with PCR swabs. No one developed symptomatic disease within the cohort that had who were seropositive for as evidence of previous infection. The difficulty of identifying, of doing this, or if you like, looking into this particular problem is the following: that early on this year, we had far many more infections than were confirmed. And do you define initial infection by symptom, in which case it's very similar to other respiratory viral infections? Or do we define it by the presence of antibody? And that crucially depends upon the timing at which those antibody assays are taken following infection. Because we know from a study in Iceland that even in individuals who are seronegative, there seems to be some T-cell receptor evidence of immunity to coronavirus in that group. T-cell immunity to coronavirus in that group. So defining what that initial infection was is a challenge. And I'm not aware of a cohort of individuals who have been followed with regards to reinfection apart from this Oxford cohort. Although it would be interesting to follow up, and I suspect it will be something far more easily done from now on in, because PCR tests are much more easily available and the serology can be more easily carried out.
Thank you, Ahmed Darsi.
Assalamualaikum. The question is regarding I think you answered part of it, is regarding the Pfizer's 21 days and then wait for another, say, 11 to 12 weeks. And you answered that we are not aware of if there is an efficacy goes down or not after 21 days if you don't have the booster dose. So up to, if you wait until like 10 to 11 weeks before you have the booster dose, first of all, what are the chances of the person getting the infection during that period? Because we do not know the efficacy, because according to Pfizer's, you need to have the second dose after 21 days, otherwise it might not maybe protect you. And after say 12 weeks, you have the booster dose. Is that booster dose effective then? Because you've had so much space in between the first dose and the second dose.
I think thank you for the question. So we know that up till day 21 and probably up till day 28 following initial vaccination, vaccine efficacy produced by the Pfizer vaccine is in the range of 90 to 92%. We're looking at these up till a month. There aren't any studies done beyond 28 days. And this 28 days is drawn from an analysis of the data provided to the FDA, and it includes a period of 1 week following the second vaccine, when we assume that the second vaccine hasn't yet taken effect. So up until that point, you've got a vaccine efficacy of 90 to 92%. The question becomes one of, is there a reason to think that there's going to be a rapid decline thereafter up until 12 weeks? And there's an absence of data on this, but there's no reason necessarily to think that there will be a significant decline. And the point of boosting at 12 weeks is that you've already induced an immune response. You're already producing antibodies, your T cells are already beginning to be active, but you want it to be more refined. You want it to be more potent. You want it to be more focused. And that is what the boosting dose does. And it also, in individuals who have had a suboptimal response, boosts that. The likelihood is that that will still occur at 12 weeks. But we'll just have to watch and see. This is, if you like, there is a risk in this. There is a risk in this. The question is whether this is a reasonable risk or not, and where we should focus our energy at this point. And I think that the focus with the 12-week debate is to make sure that there is vaccination at 12 weeks, that there isn't any further delay beyond that. Because we have in a situation where there's a scarcity, we have no means of bringing that forward. But what we can do is ensure as a group or as a community that we are organized in demanding that there is no delay beyond 12 weeks.
Perfect. Just before we ask a couple more questions, just a reminder that we have these talks every Friday. So please do come. You'll find out more on sikkim.org.uk. Next Friday, the 29th of January, we have a talk on the genocide of Uyghur Muslims in China by Aziza Isa Al-Kun, who's from the community, an activist who's active in that community. On the next Tuesday, we have a talk on Fatima, the role model for us all. And the next Friday we have Western corporations engaging in human rights abuses, the case study of Petra Diamond Mine in Tanzania by RAID UK's Executive Director Annika van Woudenberg, and RAID UK, they're an organization who hold businesses to account and are very good at this type of work. You'll see a lot more of our talks online on sikkim.org.uk. Just another couple of questions that have come through. Firstly, from Nazneen, which vaccine is best? And the next one is, how does herd immunity work? If one decides not to get vaccinated, but keeps to the pandemic rules and mostly stays at home, what is the likelihood they could still get infected and suffer fatal illnesses or die? And the third question is the 23 people who died in Norway. What was the type of death? I've seen a video of a 40-year-old woman take the vaccine with side effect looking like a stroke and difficulty walking, with the video being from her son in the USA.
So the 23 individuals who died in Norway were all of very advanced age. They had lots of underlying medical conditions. And the concern was that their deaths occurred shortly, within 4 weeks of them being vaccinated. And if you like, the rate of death was not higher than you would expect for that particular population. And it's not as if there's a single cause of death that unites all of them. It's just that they all died within a short while, 4 weeks of having had a vaccine, but not necessarily of the vaccination itself. I think you're referring to a video of a patient who had developed what's known as Bell's palsy, so facial weakness, where the muscles on one side of the face become weak. And this was identified within the trials themselves. There were 4 patients in the Pfizer trials of the 20,000 who were vaccinated or who developed Bell's palsy. And given that Bell's palsy occurs at a rate of 1 every 5,000 persons every year, this is not beyond the baseline rate. So the challenge in all of this is working out what's due to the vaccine, what's due to people's existing medical problems, and what is due to problems that may well be expected to occur. And so far, there's no signal to suggest the vaccine is responsible for anything there. Which were the other questions, Mita? Sorry.
Sorry, just which vaccine is best was one question, and the final question: how does herd immunity work? And related to that, if one decides not to get vaccinated but keeps to the pandemic rules and mostly stays at home, what's the likelihood they could still get infected and suffer fatal illnesses or die?
So if you imagine a game of catch, and you have a stadium full of people, and this virus is introduced in, and anyone initially who's touched by the virus is caught and falls out of the game. After vaccination, there will be a group of people who, even if they're touched by the virus, will not succumb to it or will not develop it, and as a result cannot then pass it on. So herd immunity here is a point at which there are sufficient number of individuals within the community who are immune or not susceptible to the infection, such that the number of infections in the community starts to decline after that. So that virus is unable to propagate itself as it would otherwise. And this is the whole point of the vaccination process, that we have sufficient number of people in the community that even if there's a small amount of virus in the area, it does not propagate and spread through the community as we're seeing today. And as to which vaccine is best, anyone you can get your hand on here from the 3 that have been highlighted: the Pfizer vaccine, the Moderna vaccine, or the AstraZeneca vaccine, either of those 3.
All right. I know that there might be other questions that have come through, but I think we've had quite a really good discussion covering all different areas. So thank you so much, Umar, for participating, for sharing your thoughts, and as an expert in this field. Just wanted to finally ask, as a prerogative of the chair, a final question to close off. What do you think about given we are Muslim and from Muslim communities, you see these videos of Muslims saying things that are so outrageously untrue? Like, how do you as a specific, both intersectionally, both a Muslim and an infectious disease specialist, how do you see this? Like, what do you do? What do you advise us to do when we see this type of thing?
I'm sure you're aware of the hadith of the Prophet ﷺ, that it is enough that you transmit an untruth or a report without verifying it, for it to be for yourself to be ultimately considered to be untruthful in that. Or hasbunallah, or as the Prophet ﷺ said. So for me, I see this as the product of a community that is paralyzed by its weakness, that feels itself marginalized, that feels itself isolated, that senses a threat in whatever comes in its way. Because often you find that these are the same people who will sit there saying that there is no epidemic, there is no problem in the UK, that this is all a concoction, just as the vaccine is a concoction and is aimed to improve control of a population. And that's interesting. I think it's very interesting that a common theme in all of this is about control. It's that others are controlling us, that others are dictating things for us, which, you know, is fundamentally goes against the grain. La yukallifu Allahu nafsan illa wus'aha. And if we have the means then to be able to overcome a challenge, it seems bizarre that we should not consider what those means are and to take this on and to overcome that challenge, rather than lying down and saying, letting the world walk all over us by denying ourselves agency through these conspiracy theories. But at the same time, I think this needs to be dealt with sympathy and with an understanding of the context, given the disproportionate number of deaths that have occurred amongst ethnic minority communities and amongst those who are socially deprived within the UK, at the hands of a government that has shown itself more interested in characterizing us as pickaninnies with watermelon smiles, walking hand in hand with letterboxes. And given that kind of logic, and given the determination by our august and esteemed Home Secretary to ensure that people who are born in the UK are shipped out to whatever fate they may face, I think this is understandable, right? They feel that the powers that be are out to get them. And yes, the powers that be are probably out to get us. We're seen as the fifth column, we're portrayed as a danger to society. But at the same time, we need to realize that we have to take each situation on the basis of what faces us and deal with it.
Thank you very much, Umar, and thank you all for joining, both here on Zoom or on YouTube or on Facebook. So thank you very much for us coming, listening, and hope to see many of you again on our regular Fridays. So just a reminder, this next Friday we do have a talk on the genocide of the Uyghur Muslims in China by Aziz Isa Al-Kun, who's an activist from that very community. So please do participate and come. It'll be the same YouTube link in the future. So thank you so much, and thank you everyone else. And we're now going to shut this live stream, but if you do want to continue and just socialize and talk to one another, please do stay on and show your video, but I'll let you know when the live stream ends in a couple of seconds.